All right, we've got quite a few people starting to jump in, so I'm going to go ahead and get started. Good afternoon and welcome to the current session, Chronic and Rare Kidney Disease in African Americans, What Everyone Should Know. My name is Akil Hunt. I'm Director of Patient Empowerment at Travere Therapeutics, who is the sponsor of this session. Travere is a small biotech company that specializes in manufacturing of treatments for rare diseases, and is currently developing potential treatment for two forms of rare kidney diseases, one of which we'll be talking about here today. I'd like to thank everyone for joining this afternoon. I get really excited about these sessions because I know for a fact that there's at least one person out there that's going to learn something new. And I know that because at one point I was one such person. For myself, before joining Travere and before learning, as much as I know now about kidney disease, I didn't fully understand the prevalence of kidney disease, didn't understand the risk for myself, for my family, or even, the African-American community. Now understanding and learning more and arming myself with information, it's actually prompted me to have a talk with my parents and my family about our own, family history. My parents come from Trinidad and Tobago, and I hadn't really specifically asked questions about kidney disease. So I really hope that, like myself, all of you were able to take something away from today's conversation. So I will be today's moderator. So if you have any questions, please don't hesitate to enter them in the Q&A chat below. Before we start, I want to introduce our two speakers. Our physician speaker today is Dr. Jason Cobb. Dr. Cobb is an associate professor of medicine in the Emory University Division of Renal Medicine. Dr. Cobb is a graduate of Morehouse College with a BS in biology. He holds a medical degree from Emory University School of Medicine and completed his internal medicine residency and nephrology fellowship at Emory. He is board certified in internal medicine and nephrology and currently sees patients in the nephrology clinic at Emory University Hospital, Midtown, and manages various chronic kidney diseases associated with diabetes, hypertension, and vascular diseases. Our patient speaker this afternoon is Kevin Mott. Kevin is an FSGS patient living in the Chicago area. Early on, Kevin said that he has had a tough time finding doctors who would take his symptoms seriously. And he really, as you hear from his story, emphasizes being your own self-advocate. He actually had to see 4 medical professionals before finding his nephrologist, who finally diagnosed him properly. Kevin is also been the recipient of a kidney transplant and works very closely with NephCure's board of directors. And Kevin, I'll toss it over to you to tell us a little bit more about yourself.
Thank you, Akil. Good afternoon, everybody. I want to say good afternoon to our guests for joining us from all over the country. And I want to give a special introduction to my brothers of Kappa Psi fraternity. My name is Kevin Mott. I'm a Spring 88 initiate of the Epsilon Eta chapter. I'm a member of the Evanston Alumni chapter, and I am the president of the Paul W. Kane Foundation that is affiliated with Evanston Alumni chapter. And thank you for joining us. So I'm here wearing a couple of different hats. One as a Kappa, enjoying our conclave for one. And then also I'm here as an FSGS patient and a NephCure board member. And I want to tell you a little bit about my journey with FSGS. And for me, it started around 2002, 2003. I was in my early 30s. I was having a problem with migraines. And it got so bad, like most men, I didn't necessarily go to the doctor at the first sign of discomfort, but it got to the point where I knew I had to do something. So I went to a doctor and we discovered that my blood pressure was extremely high, which was a little surprising to me. I'm someone, I like to cook. I try to cook healthy. I always exercised and everything. So I wasn't necessarily expecting that. Excuse me. So we tried a few different medications. None of them seemed to work. And one day talking to this doctor, he says to me, well, Kevin, none of these medications are going to work if you don't cut back on fried foods and canned goods. And as I said, I'm someone who likes to cook. I cook healthy. I looked at him. I said, I don't eat like that. So I don't know what you mean. And he kind of looked at me and said, yeah, cut down on the fried food and the canned goods. So at that point, I decided I need to find another doctor. I went to another doctor. Same thing happened. I'm having these migraines. My blood pressure is really high. We're trying medications. None of them seem to be working. That doctor said to me, even if it was years ago or whenever, but if you've used drugs like cocaine, they can limit the effectiveness of these medications I'm trying to do. I said, I have no idea where you got that from. That has not come up. That is not my history. I've never done drugs or anything like that. So I decided, all right, this doctor I also, need to change from. So I go to a third doctor. Same thing is happening. You're having these migraines. Your blood pressure is high. We're giving you these medications. None of them are working. That one, at least, defaulted to another preconceived notion. He said, well, if you're using HGH and steroids and things like that, and I was in shape, but I wasn't in that kind of shape. It's not like I looked like The Rock or anything. But once again, this doctor, I got to a point where he was filling things in based on no information he had gotten from me. So one day at work, I'm having the same thing. I have these migraines. I'm looking for a doctor. I call my HMO. They say, well, the only doctor we can get you in to see is at this women's clinic. I was in such discomfort. I said, I don't care. I just need to go see a doctor. So I go to this women's clinic and I begin for the first time to have a dialogue and a conversation with this physician. And at the end of my appointment, I said to her, clearly you didn't plan on having a lot of male patients, but if you take me, I'd like to stay because this is the first time I've had a dialogue with the doctor. And so I did. And, it was the same thing. We were giving me blood pressure medications. Nothing seems to be working. But the good thing for me is at some point she said to me, based on what I know about you, it doesn't make sense that we're having this hard of a time getting your blood pressure under control. I want to send you to a nephrologist. I didn't know what a nephrologist was. I didn't know what that meant. But I went to the nephrologist and she told me, that it looked like I had the signs of FSGS. We eventually did a biopsy and it's, yes, you have FSGS. And what I was told at the time was what is normal is that after diagnosis, within 2 years, it's normal for someone to either be on dialysis or in need of a transplant. So, that wasn't fun to hear at 32, 33 years old. I was very fortunate. I had a very long, slow progression in my condition. And it wasn't until 2015 that my nephrologist said to me, you're about 2 years away. You need to start telling people that you need a kidney. And most of my friends had no idea that I had any health issue whatsoever. So that first round of telling people, it was about 30, 35 people that I considered friends and that I trusted with my information, that I trusted to talk about me, that I reached out to them and said, well, this is my condition. This is where I am. I didn't ask anyone to give me a kidney, but what I said was feel free to tell people about, what you've heard about me, just to get it out there. And I was very fortunate. I had about 3 or 4 people get to the point where they could get the full screen to get tested. I was very, very fortunate. I had people that wanted to get tested and wanted to donate to me. But so that was 2015, going into 2016, I still hadn't found a donor. So I made a big post on Facebook and told everybody what my situation was and asked, for them just to spread the news as much as they could. And fortunately for me, in 2017, a good friend of mine from college decided to donate. And as a matter of fact, yesterday is my 4th year anniversary of getting my transplant. I've been very healthy. I've been very fortunate. Everything is going well for me. I had an excellent recovery. I've had great physicians along the way. And because of how blessed I was, I've decided to get involved in working with other African-American men in particular on kidney diseases, FSGS in particular. So that's my story. That's how I'm here. If you or anyone in your family is struggling with this, I appreciate that you're here listening to. I hope we give you something that's very helpful. And 3, please go to NephCure Kidney International, nephcure.org to go for information about the disease, about nutrition, about the diet, about many different things. So with that, I'm going to turn things over to Dr. Cobb to tell you what exactly FSGS is.
Thanks, Kevin, for sharing your story. And we will talk a little bit about chronic and rare kidney disease in African Americans, what everyone should know. So chronic kidney disease in African Americans, so CKD, chronic kidney disease, occurs when the kidneys are no longer able to clean toxins and waste product from the blood and perform their functions to full capacity. In the United States, about 13% of adults will have chronic kidney disease. So that's 37 million people in the US that have kidney disease. If diagnosed early, kidney disease can be slowed or even stopped. African Americans make up 13% of the US population, but account for 32% of kidney failure in the United States. So definitely, we only account for 13% of the US population, but 32% of kidney failure is definitely disproportionately affects African Americans. African Americans are almost 4 times more likely to develop kidney failure than Caucasians. The primary diagnosis for patients who start dialysis. So the most common cause of chronic kidney disease and kidney failure, where the person with chronic kidney disease actually need dialysis, is diabetes. It's about half of the population with chronic kidney disease and end-stage renal disease or kidney failure. Number 2 is hypertension, about 27%. One thing that we want to really share today is bring more information to that glomerulonephritis area. So these special things that nephrologists like myself might specialize in, things such as lupus nephritis, and what we heard from Kevin today, FSGS, focal segmental glomerulosclerosis. And we work with NephCure, which is a company that brings attention to those rare kidney disease, that 13%. So what is FSGS? Focal segmental glomerulosclerosis. It affects some sections of the kidney and that end up being scarred over time. FSGS is a disorder that affects the kidney's filtering units. They stop filtering the blood properly and protein spills into the urine. FSGS disproportionately affects African Americans, and especially those from West African descent or the Caribbean. And that's the majority of African Americans. So what are the symptoms of FSGS? So normally with chronic kidney disease, we don't usually talk about things like dialysis until kidney function gets to about 10%. You can actually live with a very small amount of kidney function and live a pretty normal life. Unfortunately, that's why we see some people who do not present to the hospital until they are in complete kidney failure because they weren't getting primary care checks, they weren't getting physicals, they weren't getting their blood work done. Unfortunately, kidney disease can present pretty late because your body can really live on a very low amount of kidney function. But some of the special things such as FSGS, lupus nephritis, they can actually start developing some symptoms early. So patients might notice they have foamy urine. That's usually a sign of protein in the urine. Like Kevin mentioned earlier, elevated blood pressure, swelling in the body, especially in the feet, the abdomen. They might get a low albumin, so you're losing protein in your blood because you're spilling the protein out in your urine. So you end up getting complications like high cholesterol. Then unfortunately, if this is not treated, you'll start getting an elevation in your creatinine. So your kidney function is starting to become lower if your body's not responding to treatment to FSGS. So how is FSGS diagnosed? So normally for kidney disease overall, we do blood work looking at your creatinine, and we do urine tests looking for protein or blood in your urine. But your special things like FSGS, you actually need a kidney biopsy, where we take a long needle, but we take just a very small amount of that kidney and send it to the lab. So FSGS is definitively diagnosed with a kidney biopsy. Some familiar faces with FSGS. We may know Alonzo Mourning and Sean Elliott, both NBA players that were diagnosed with FSGS, and Alonzo Mourning to the point where he needed a kidney transplant. So this is an exciting time in nephrology. We actually know some things about the genetics of why African Americans have more chronic kidney disease compared to others. And we also know that genetics are also involved in some of these rare kidney diseases such as FSGS, like focal segmental glomerulosclerosis. So this gene that we're talking about is ApoL1. And one big thing with groups such as NephCure, We're trying to educate people about APOL1 and possibly get patients even tested. 1 in 5 people have 2 copies of APOL1. So if you do, unfortunately, you're at risk for kidney disease. APOL1 genetic variants account for 70% of non-diabetic kidney failure in African Americans. And we know about 4 in 10 African Americans on dialysis have this genetic defect with APOL1. So how is FSGS treated? Currently, there are no medications approved specifically for FSGS, but we know if we treat the underlying disorder, some people just have FSGS, but some people might have FSGS due to other things, such as obesity. We use medications to treat blood pressure, and some of these special blood pressure medications might also help with the protein in the urine. But a lot of patients will need something stronger, such as immunosuppressive medications that try to decrease the inflammation in the kidneys, so medications like steroids. So patient resources on chronic kidney disease, but also specifically some of these rare kidney diseases like FSGS, go to nephcure.org. Nephcure is a great company for research, but also patient education. The American Association of Kidney Patients, AAKP, the National Kidney Foundation, and groups like today, like blackhealthmatters.com. Thank you.
All right. Thank you, Dr. Cobb. Thank you, Kevin. This time, we've got a couple of questions in the Q&A chat. If you have any additional questions, please don't hesitate to put them down in the chat. Dr. Cobb, first one's for you. Can you go back and talk through a little bit closer the symptoms for FSGS? There's some questions about high blood pressure, but there's also a couple questions about the foamy urine. If you could talk about that a little bit.
Okay. So not just FSGS, but a lot of the rare kidney diseases might be associated with what we call nephrotic syndrome, where people spill a lot of protein in the urine. And early things that you might notice is foamy urine. And at that point, you might not even have symptoms. And that's why it's important to get physicals, get your blood work checked. So it could be caught early. We can see change in kidney function. We can notice the protein in the urine on your physical. But as the protein in the urine get worse, patients can start having edema where they start swelling, especially in the legs. If the swelling gets worse and as the protein in the urine gets worse, you can get swelling in the belly. And I'm on hospital service right now. We see a lot of patients with glomerulonephritis or FSGS. They end up getting fluid in the lungs, and that's a medical emergency. Outside of that, if the kidney functions get worse and you have worsening chronic kidney disease, other symptoms people can have, we talked about elevation of the blood pressure. When people get closer to dialysis, some people might notice a decrease in appetite, fatigue, lack of energy.
A lot of questions about potential home remedies or things to do on a daily basis, particularly diet. Questions about dandelion teas or any other homeopathic remedies, and particularly, is there anything to do to kind of extend or keep the kidneys from becoming damaged? Any things that foods or anything you recommend?
Okay. So I do understand the interest in home remedies and natural things. I really do think when it comes to kidney disease, the big thing is prevention and also early detection. You really, even if you feel fine, you got to get physicals, you got to get your blood work checked, you got to get your urine checked. Because unfortunately, a lot of these things, you won't have symptoms until you're in full-blown kidney failure and almost at dialysis. And unfortunately, on hospital duty here in Atlanta, I see this quite often. But overall, a healthy lifestyle, diet and exercise, low sodium diet, less than 2,000 milligrams of sodium a day, low cholesterol diet, avoiding fatty foods, a healthy lifestyle overall. And once you have kidney disease, those things are even more important. We have machines such as dialysis that can replace your kidney function when your kidneys fail. But the majority of patients with chronic kidney disease do not make it to dialysis. They actually die from heart disease. So that's why it's very important to control your blood pressure, control your cholesterol early in the process.
I have a question for Dr. Cobb. Dr. Cobb,
Yes.
in a normal physical, am I going to have the test where they test my for my protein in urine, or is that something that I have to ask for?
Great question. So on a normal physical, once you get to about the age of 40, the blood work in the urine protein probably would be included. Sometimes, unfortunately, though, in younger patients, they might only check for certain things. So as an African-American patient, I've been getting my creatinine, my kidney function checked, my urine checked a lot earlier, and you might have to ask for it when you're a younger patient, because certain things in healthy adults, they might not check. But you need to be an advocate for yourself, especially I think all African-Americans need to be checked early, and especially you have a history of kidney disease. Actually, that's why I'm a nephrologist and interested in nephrology. I have some close family members who are on dialysis.
Kevin, I'll send this one over to you. There's some questions about kind of the kidney transplant process. How has it might have changed over the years? I know yours is a little bit more recent, but just kind of what that experience was like, and how do you go about having that conversation with either family members or beyond?
Well, one, my blood type is O, so I'm the hardest. I was in the hardest group to match, and I wasn't quite sure that I would get a match from some of my family members. I knew some of the family members that I would would typically most likely be a match, also had high blood pressure or other issues. So I was added to the list, but once again, like I said, for my blood type, typically it took about 5 to 7 years to get a transplant from the donor list. I had to, at a certain point, even though I did not want to, for a lot of personal reasons, I had to just start telling people what I was dealing with, where I was, and what I needed. And I never asked. I just told, and I gave my friends permission to talk for me. And that's one thing that I always encourage people to do. As a matter of fact, the day I got back to my office from recovering from my surgery, I found out that one of my clients had been diagnosed with FSGS. And that's been part of my advice to him, is that you just have to tell people. And I always say, let people love you the way they're going to love you. It's not up to you to decide for other people what they will or will not do for you. One of my good friends just became a very loud and adamant advocate for me. She was in all of our school alumni groups, telling people Kevin needs a kidney. Yeah, my friends really surrounded me and are the ones who really made sure that my recovery was really good. So I think you just have to tell people in a way that's comfortable for you. That maybe there's some people you want to talk to and let them give them permission to be the advocates for you. But you just have to get out there and start talking, because statistics do show that it is better to get a kidney from a living donor. And you never know. The person who donated to me is a friend, but I never expected that he would donate. So, just talk to people, talk about it, and look for resources online to help you figure out how to get your message out.
Yeah, a lot of questions about that kidney process. Did you feel comfortable? Obviously, you knew you're able to find a donor. I think there's people talking about kind of privacy claims. Were there any times where you felt that you had the right information or knew where to go in order to get the information, or is it just really a lot about that self-advocacy?
Well, I think that it's a very there's a high amount of liability in it, so you do get a lot of information. And I do know that people are told something about the background of the person, the kidney that might be available. Because I know people that have said, based off of what you've told me about this person's lifestyle, that's not a risk that I want to take. Or, based off of, conditions that this person might have had, I don't want that. So they do give you a lot of information. Actually, I just saw a question from somebody that says, what do I do differently after transplant to opposed to before? Actually, I don't do much differently at all. I already had a fairly healthy lifestyle. I pay a little bit more attention to salt. So, you know, if I'm eating salty food, most of the time it's because I'm eating out. So I'm more aware of it. That's about the only thing. But other than that, like Dr. Cobb said, a healthy lifestyle is what's good for your, you know, good for your kidneys. So I was already someone where, you know, I like to cook. So I was cooking my own food. I would, you know, make sure, you know, buy the organic, this, that, or the other. I was, you know, making sure that there was more green on my plate than there was more meat, you know. All those things are just things you have to do. So I don't really have a lot that I have to do differently because I was already doing that before.
Right, that's great.
Great advice, Kevin. One thing I wanted to say, though, if you have chronic kidney disease or you have family members with it, make sure they get referred early. You do not have to be on dialysis to get on the kidney transplant waiting list. That's
I'm sorry.
people think. Yeah. Then
Yeah,
also, if they're on dialysis, make sure they get referred, because unfortunately a patient has to be referred by their nephrologist to the kidney transplant center.
Yeah, I think dietary concerns are much bigger for people who are on dialysis. There's a lot more restrictions. You know, things that you would think are healthy foods are not necessarily good for people on dialysis. So that's a much more complex thing.
Okay, Dr. Cobb, back over to you. Question about the role of the APL1 gene, and specifically, you know, now that we're kind of, you know, using it as a marker and a target, is that, you know, more likely that we'll get, you know, better treatment outcomes or better treatments down the road, or is it something that, you know, people can now kind of avoid trying to, you know, do research in those specific areas? There's a couple of questions just about, you know, the transparency now that we've identified some of those markers.
Well, that's the thing. This is new research within the last 10 years, and there's a lot. We actually enrolling patients in some studies now looking at FSGS and APOL1, because the goal is that instead of treating all FSGS patients the same, like I said, we don't have any specific treatment for FSGS right now. There's medications that we use for other things that we kind of try to see, do they work in FSGS? So hopefully we can get some specific medications for APOL1 related FSGS and kidney disease, which I think will be a big development in nephrology. The other thing too, testing wise, I do think it's important that we understand why. Like for a while, we was like, African Americans get so much more kidney disease on dialysis, so much more compared to others. So it's very interesting that we kind of think we know why is this genetic disorder.
Okay. And specific to diet, you mentioned kind of low sodium diet. There's a couple of questions about protein, how much protein is appropriate. I would imagine it depends on kind of where you are on the CKD spectrum, but can you talk about maybe some high level insights in terms of diet and different types of things to consume?
Yeah, so definitely low sodium diet, low cholesterol diet. But Kevin kind of mentioned earlier too, the diet is really different between your stages of CKD and somebody like on dialysis. Also, patients with rare kidney diseases like FSGS, we might limit the protein intake, but someone who's closer to dialysis or actually on dialysis, that's why most dialysis units have a dietitian associated with. We really restrict the protein intake in those patients. So as an overall healthy lifestyle or early CKD patient, I don't think you really should limit your protein that much. But if you get to a certain level though, there are big changes that we need to do in your diet.
Okay. And one or two more questions. If you have any additional questions, please send them in. The role of water. There was questions about carbonated water versus, you know, some kind of the water supplements, things like that. But you know, talk a little bit about water and water intake and those type of things.
Water is good, and water has no cholesterol in it and it has no sodium in it. So that's the best thing you could possibly drink.
Awesome. And then last question, can you talk about the different types of FSGS? There's some questions about like FSGS and other conditions like lupus, things like that. Can you just kind of talk about the different types of FSGS?
So we didn't have a lot of time today, but actually that is my interest. So you have FSGS that's idiopathic, you just get it. And it's probably high association with APOL1 genetic disorder. But then you got some secondary causes of FSGS. So we treat the underlying disorder more. So obesity-related FSGS, there's a special HIV-associated FSGS, lupus podocytopathy, which is specific FSGS associated with lupus. Sickle cell patients can also have a special type of FSGS.
Again, I'm going to try to squeeze in a couple more. So some of the questions about, do I need to go to a specific FSGS doctor if I was recently diagnosed, or is it, or is just there like a broader nephrologist, or, you know, who should I be seeing now that I'm diagnosed?
It also depends on how comfortable that nephrologist is seeing certain things. So I'm in a metropolitan area at the university, and a lot of my patients are referrals from other nephrologists. So I think you really do have to have an honest conversation with that nephrologist about how comfortable they are with the special or the rare kidney diseases like FSGS. Because there's definitely academic centers that you have people that specialize in FSGS and other rare kidney diseases.
And I would say on the NephCure website, there's a link to something called kidneyhealthgateway.com, I believe. And we have a list of doctors or nephrologists there who are considered experts in FSGS. So if you needed to, you know, go, if you don't like the doctor that you have, or you just wanted a second opinion, there is a resource where we list doctors that we know have expertise in dealing with patients with FSGS.
And then there's a couple of comments about the use of NSAIDs and CKD. Any thoughts or comments on that? I think like Aleve using like that and chronic kidney disease.
If you have chronic kidney disease, I know patients don't like to hear it. Only Tylenol or acetaminophen is generic for Tylenol. All the rest of them, NSAIDs, decrease the blood flow going to the kidneys and bad on the kidneys long term.
And then the last thing, can you go back to the slide that spells out FSGS? I think some people wanted to be able to kind of see that one more time. Perfect.
There you go.
And with that, unfortunately, we are out of time. I'm sorry for those that wasn't able to get to your questions. I know there were a couple people trying to get me on both the chat and the Q&A, so I apologize for that. Like Dr. Cobb said, we didn't have a ton of time, but I hope that you were able to get a lot out of the conversation. Dr. Cobb, Kevin, there's a lot of thank yous and a lot of great information in the chat. So I want to say on behalf of everybody listening, thank you so much, Kevin, for telling your story, and Jason or Dr. Cobb for presenting your point of view and for educating us a little bit on FSGS. So thank you to you both.
Thank y'all so much.
Thank you all.
All right, everybody, with that, thank you so much. Please don't hesitate to go to our booth at the Black Health Matters Pavilion and let us know if you have any additional questions. Thank you so much.